Hi, this is Dr. Bhargava. In this video, I'm going to be sharing 20 interesting body imaging cases with you all. Here's our first patient. And so this patient underwent CT of the abdomen and pelvis with contrast, and an incidental finding was seen in the uterus. There is an enhancing focus that is seen right here, and it is seen to grow into the endometrial cavity from the myometrium, also seen here on this sagittal image. So this is a polypoid fibroid. It is showing contrast enhancement, and it is growing from the uterus into the endometrial cavity, and it probably started off as a submucosal fibroid. Here we have a diagram from a recent article published in Radiographics showing a new FIGO location-based subclassification of leiomyomas. So the fibroid that we saw in the previous slide would be a stage 0 submucosal polypoid fibroid. Here's our next patient, and the finding is in the spine shown in the bone windows on the sagittal view. We find that the vertebral bodies are hyperdense, and near the superior and inferior end plates we see the hyperdensity, and in the middle there is some lucency. Also on this axial image we notice that both of their kidneys are atrophic, and so this patient has findings from renal osteodystrophy, and this particular finding that we see in the spine is called Rugger-Jersey spine. And here is an image from the internet showing hyperdense vertebral bodies near the superior and inferior end plate with a lucency in the middle, and its appearance being compared to a Rugger-Jersey. Our next patient presented with right lower quadrant abdominal pain, and we performed a CT of the abdomen and pelvis with contrast. And this patient's CT shows this tubular blind-ended structure in the right lower quadrant with some proximal focal hyperdensity and surrounding inflammatory changes. So this is classic example of acute appendicitis, also seen here on the sagittal image, and also on this transaxial image we see a very enlarged, distended and dilated appendix with a lot of periappendiceal inflammatory findings. Here is an example from the literature of acute appendicitis seen on ultrasound, transaxial image of the appendix, and also the sagittal image showing a tubular blind-ended structure, which is the appendix. It shows mural thickening and hyperemia and some surrounding fat stranding. So a good example of acute appendicitis on ultrasound imaging. This is our next patient, a young female presenting with abdominal pain who underwent CT of the abdomen and pelvis, and the finding is in their kidneys. As we compare the two kidneys, we find that the left kidney is normal. It shows uniform enhancement of the cortical parenchyma, and we see the same finding here on the left side on the coronal image. And on the right side, we find that there are small areas of hypoenhancement in the right kidney. And so these foci of hypoenhancement are consistent with acute pyelonephritis. This is a very common finding and a common cause of abdominal pain in young females. The infection starts from the urethra, and then it involves the urinary bladder, and frequently it ascends the ureter to involve portions of the kidneys unilaterally or bilaterally. It's important to be familiar with the renal anatomy. This is an image or a figure from the literature showing the cortex, the renal pyramid. The pyramids end in the minor calyces labeled right here. Minor calyces, they join to form major calyces, and then the major calyces continue as the collecting system and the ureter. Here's our next patient. On their plain film, the finding is multiple foci of sclerosis involving the pelvis, the iliac crest, ischium, proximal femurs. And so these foci of sclerosis suggest multifocal osteoblastic bone metastasis, and this is a coronal image from their CT in bone windows showing in better detail the osteoblastic bone metastasis in this patient with prostate cancer. Here is our next patient, and a CT of the chest was performed with IV contrast, and on the CT in multiple projections we find that there is a filling defect seen right here, also in the coronal and in the sagittal images. This filling defect is in the superior vena cava as it comes down to drain into the right atrium, and this filling defect is consistent with a clot or a deep venous thrombosis extending into the SVC. With the upper extremities, we want to make sure that we are familiar with which veins are considered deep veins and which veins are considered superficial veins, because a thrombus seen in a deep vein would qualify as deep venous thrombosis, would predispose the patient to pulmonary embolism, and a thrombus in a superficial vein would be consistent with superficial thrombophlebitis. So going from proximal to distal, deep veins of the upper extremities are subclavian vein, axillary vein, brachial vein, and also radial and ulnar veins. The other veins shown here in light blue and labeled are superficial veins. Here is our next patient. They presented for a whole body bone scan looking for bone metastasis, and we found on this anterior image a focus of intense uptake in the sternum. And notice that this focus is not seen on the posterior image, and that's characteristic of nuclear medicine. The anatomy that is closer to the camera head is better visualized on images, and the anatomy that is further away from the camera head is not well visualized. So on this posterior image, the spine is closer to the camera head, so that is better visualized. Also, this patient was probably a little claustrophobic, and they did not tolerate the camera head right in front of them, very close to them, and so the technologist moved the camera head slightly away, leading to a worsening of image resolution. Now, what happens with new trainees is that when they see something like this, they jump on it and say that there is focus of increased uptake consistent with osteoblastic bone metastasis. But remember, all that glitters is not gold on nuclear medicine, and so you want to correlate the findings with patient's history. This patient had a history of renal cell carcinoma, and we know that renal cell carcinomas lead to osteolytic and not osteoblastic bone metastases. Also, paying attention to this focus, we notice that bilaterally there are several foci of increased uptake seen anteriorly in the chest at the junction of the ribs and the costal cartilages. So this looks more like trauma rather than bone metastasis. So, and this turned out to be a fracture on their CT as seen on this sagittal image in bone windows. So remember, fractures can be seen as foci of increased uptake on a bone scan. Here, let's briefly review how a whole body bone scan is acquired. We inject patients with about 30 millicuries of technetium-99m MDP or HDP, wait for 3 hours, then put them on the table. The anterior image is acquired by this anterior camera head, and the posterior image is acquired by the posterior camera head, which is behind the patient, and the patient is lying on the table, and the gantry moves in one direction, superior to inferior or inferior to superior, to acquire a whole body image. This picture was downloaded from the internet. Here is our next patient, and we are looking at two views from the CT of the chest. On the axial image, we find that there is a large fluid collection around the heart, and we see the same thing on this coronal image with minimal enhancement of the pericardium, which is seen right here. Right, so this patient has a large pericardial effusion, and this is its characteristic appearance on CT. And when you find that there is enhancement of the pericardium, and if there is air inside this fluid collection, then we want to raise the suspicion that there is superimposed infection, and it's an infected pericardial effusion. This is an example from the internet showing enlarged cardiac silhouette from pericardial effusion on a chest x-ray, and its appearance being compared to a water bottle And we frequently say that when the cardiac silhouette is enlarged in this fashion on a chest x-ray, that there is a water bottle sign, and consider a pericardial effusion as the cause of this enlarged cardiac silhouette. This is our next patient. They presented with headache and palpitations, and they first underwent a CT which showed a mass arising from the right adrenal, and then they had an MRI to better evaluate that mass. This is a large mass that is arising from the right adrenal. We are seeing some T2 hyperintensity in this focus. Also seen here on this axial fat saturated T2 weighted image. We find that this mass has some internal T1 hyperintensity suggesting some hemorrhage, and it shows uniform contrast enhancement. It also shows restricted diffusion. Here we see high signal on DWI images, low signal on ADC. So it's a malignant mass arising from the right adrenal. And there are two possibilities here, an adrenocortical carcinoma or a pheochromocytoma. Based on patient symptoms and labs, the diagnosis of pheochromocytoma was made and this mass was resected. With adrenals, we want to know that it has two parts, cortex and the medulla. Medulla is neuroendocrine in origin, has sympathetic ganglia which secrete adrenaline and noradrenaline, and the tumors arising from adrenal medullas are pheochromocytomas. When pheochromocytomas arise outside the adrenals, they are called paragangliomas. And also the cortex has three different layers. From outside to inside, there are zona glomerulosa, zona fasciculata, and zona reticularis, with three different kinds of secretions. So if tumors arise from any of these layers, they will secrete one of these three kinds of hormones. Here's our next patient. We are looking at frontal and lateral views of their chest x-ray, showing this linear lucency below the right hemidiaphragm and also below the left hemidiaphragm. And so this is a great example of a pneumoperitoneum. Whenever there is pneumoperitoneum on plain films, we want to raise the suspicion that this patient may have had bowel perforation and the air has escaped from the bowel loops and has accumulated in the subdiaphragmatic region, or correlate with the patient's history to see if they've had recent surgery or a laparotomy, in which case free air can persist for 7 to 10 days. This is a picture from the internet showing all different kinds of signs that we can see in patients who have pneumoperitoneum, especially on plain film. So we got a cupola sign, Wriggler sign, football sign, and the silver sign. So, and these signs are helpful in making the diagnosis of pneumoperitoneum on plain films. This is our next patient, a young female with history of myasthenia gravis. She underwent CT of the chest, and the images show this large lobulated enhancing mass in the anterior mediastinum, seen also right here on the coronal image and the sagittal image. There are no calcifications, there is no necrosis, and there is no fat inside this tumor. It's uniform, it's lobulated, and it's enhancing. This turned out to be a thymoma at surgery. This is our next patient, another young female who was admitted for acute appendicitis, and the chest x-ray before their surgery showed this large mediastinal mass seen on the right side. And so this was evaluated further by CT, and this mass, in contrast to the previously seen case, shows thick peripheral calcifications, internal focus of fat, and not as much enhancement. And so this mass turned out to be a teratoma. This is our third patient, a companion case, a young male with cough and chest pain, and a CT of the chest was performed. It shows this large mass in the anterior mediastinum, probably a conglomerate of different masses or lymph nodes. This is the appearance on the coronal image, and here this anterior mediastinal mass is seen on the sagittal image. So this turned out to be a lymphoma. So we just reviewed three different kinds of anterior mediastinal masses: lymphoma, teratoma, and thymoma. Now switching gears to pelvis, here's a patient being evaluated for high PSA. They underwent a MR of the pelvis without contrast. On the top, we have T2 weighted images in the sagittal projection showing this T2 hypointense focus right there. Also seen here on the axial image in the left peripheral gland, and also seen right here on the coronal image. This focus shows restricted diffusion. We see high signal on DWI images, low signal on ADC, and it meets the criteria for being a prostate cancer. This was biopsied and prostate cancer was confirmed. This is a picture from the internet showing the different PI-RAD categories and how to reach the diagnosis of a particular PI-RADS category. So for lesions that are in the peripheral zone, we want to use the signal intensity from DWI and ADC images, and the tumors that arise from the transition zone, we want to use signal intensity from T2 weighted images and give them one of these PI-RADS categories. So this patient underwent a prostatectomy and soon after that presented with rising PSA. And so a F18 PSMA PET-CT was performed. Here's a rotating image. And on this rotating image, we see physiologic distribution of the tracer and a focus of abnormal uptake in the pelvis. This focus in the pelvis corresponds to a tiny lymph node that is seen here, and also on the low-dose CT, a part of the PET-CT right there on the axial image. And this was consistent with their prostate cancer recurrence that was visualized on a PSMA PET-CT after their prostatectomy when they presented with rising PSA. All right, here's our next patient, and on their CT of the chest, on this coronal image in the bone windows and also in the sagittal image, we see this linear hyperdensity in the mid-esophagus. Now this is its appearance on the SCOUT images of the CT, the anterior, the AP projection, and also the lateral projection. And this is a Bravo capsule that is used by the gastroenterologist to monitor pH of the lower esophagus in patients who have gastroesophageal reflux, and it usually stays in place tucked onto the wall of the lower esophagus for 48 to 96 hours. This is how that device looks. Here's our next patient. They presented with history of prostate cancer, and the prostate cancer was treated, and they presented with rising PSA. And on their whole body bone scan, there is this very subtle focus in the midline in the spine, which was felt to be suspicious for metastatic disease. There are no other foci of increased uptake to suggest osteoblastic bone metastasis. This patient also underwent a PSMA PET-CT, and here's the rotating image from that PSMA PET-CT showing a supraclavicular node uptake, the Virchow's node. Then we see uptake in retroperitoneal lymphadenopathy, pelvic lymphadenopathy, and here is that focus that we see in a vertebral body corresponding to a sclerotic lesion, and this is the same focus that we saw earlier on the whole body bone scan. And so here you can appreciate the contrast difference between a PSMA PET-CT and a whole body bone scan when we are looking for bone metastasis. And here is the left supraclavicular metastatic node, also called the Virchow's node. All right, so this is our next patient, and here on this slide we're looking at multiple images of the stomach in the anterior and posterior projections. We've performed a gastric emptying study, and we are looking at the retention at several time points. And so here at the end of 4 hours, about 50% stays in the stomach. So this patient has severe gastroparesis. And so when we evaluate these numbers on a gastric emptying scan, we follow these limits And this is a table from the literature showing that at the end of 4 hours, normally it should be, the retention should be less than 10%. At the end of 3 hours, it should be less than 30%. At the end of 2 hours, it should be less than 60%. And at the end of 1 hour, the gastric retention should be less than 90%. So we use these limits at different time points, and then we come up to a conclusion whether the gastric emptying is normal or delayed. Here's our next patient. This patient presented with right-sided flank pain, and a CT renal stone protocol was performed. We find that the right kidney is enlarged compared to the left. There's also hydronephrosis, and in the pelvis we find that at the right UVJ there is a punctate obstructing stone. So this patient has an obstructing stone at the UVJ, and this is a 18-year-old female. 1 year ago, they had a CT, and on that CT, a non-obstructing stone was found in the right kidney, and it is this stone on the current study that has moved from the kidney collecting system, ureters, and has gotten stuck at the UVJ. So in such patients where you find obstructive stones, if you look at the prior study, you'll find that particular stone that has moved from the kidney into the collecting system and is now causing obstruction. Here is our next patient. We have two views. One is a chest x-ray and the other is an image of the abdomen. They have several findings. They have a tracheostomy tube. They have a central venous catheter. They have post-surgical changes. On this image, they have a Dobhoff tube in the stomach. But the incidental finding here is that the bones overall are hyperdense. And we see that finding on the chest, and we see that finding in the abdomen as well. So this is a patient with history of osteopetrosis, because of which they have hyperdense bones seen on the radiographs. These are modified barium swallow images from different patients showing findings. So here on the first patient, we find that there are large cervical osteophytes indenting the contrast column, and so they may be a cause of this patient's dysphagia. Here we find that there is a large flowing osteophyte, and there is ankylosis of these vertebral bodies. These three cervical vertebral bodies are fused, and there is a large osteophyte causing mass effect on the contrast column. And here in this third patient, we find that they have a diverticulum arising from the posterior wall and protruding between the esophagus and the cervical spine. And so that would be consistent with the diagnosis of a Zenker's diverticulum. Thank you for watching.